Okay, then we have here your microcytic hypochromic anemia. So, again, this is characterized here by the MCV more than, less than 80 FL and MCHC of less than 31 grams per DL. The first one, we have your iron deficiency anemia characterized here by an increased RBC loss. Because remember that your iron usually are incorporated in hemoglobin. So pag madami tayong na nawala ng mga RBC is also automatic na nawawala din ang ating iron content. Okay, so that's why you have here RBC loss exceeded the absorption of the iron. So that's why it would have a decrease na serum iron. We have also negative balance occur here with the iron concentration, decreased serum iron, and therefore ang storage iron wala ka rin. Wala kang ferritin or even your hemosiderin which are your storage iron. And therefore, since na wala kang mga protein na tinatransport, yung transport protein natin, the transferrin also is increased. And TIBC, total iron binding capacity, is also increased because again, your TIBC represent the concentration of your transferrin. Okay, we have here the causes of your iron deficiency anemia. Number one, insufficient intake. Okay, so insufficient intake, wala ka talagang makain. Second one, inadequate absorption. Meron ka nakakain but eventually hindi ma-reabsorb. It's because may problem sa ating small intestine. Nasira ang ating microvilli. It's maybe because of your sprue, your gastrectomy. So eventually hindi ma-absorb ang ating iron coming from the food that we are eating. And therefore, mangyari, wala ka ding serum iron. Another one, increased demand, especially for the pregnant patient because of the baby, di ba? And the fourth one, pinaka-common cause ng iron deficiency anemia would be your gastrointestinal tract bleeding or bleeding disorder related to that. Again, pag may blood loss, most likely your iron incorporated in that try to go along with that, so it will also result in loss of the iron. And that's all result here to your iron deficiency anemia. Another one, we have your iron transport deficiency anemia or your transferinemia. From the words of iron transport deficiency, so hindi siya nagtatransport ng iron. And eventually, pag hindi na-transport ang iron natin to your developing the RBC or erythron, so ang mangyari niyan is your RBC, wala silang iron, ang kanyang hemoglobin, kanyang heme. Bakit wala siyang iron, walang nagtatransport? It's because number one, wala kang transport protein na transferrin. So, wala magta-transport ng ferric iron and then reduce to your ferrous iron incorporated to your heme, protoporphyrin ring to form your heme. Another one, meron ka namang transferrin kaso nga lang defective. So, meron nga pero wala namang silbi. The first one, wala ka talagang transferrin. Second one, meron pero hindi siya nagta-transport. The third one, we have here your anemia of infection or your inflammation. So this is there are three etiology for anemia of infection inflammation. Number one, impaired mobilization of the iron because of the defective na histiocytes where it do not release iron. And the second one, impaired response to your anemia. And third one, we have your increased red cell destruction. Okay, increased red cell destruction and eventually resulting here to your shortened RBC survival. Madami ang nag-rupture, so therefore, hindi pa nila na-reach ang 120 days na mamatay sila agad. That's your shortened RBC survival. Okay, another example of your microcytic hypochromic anemia, we have here your sideroblastic anemia. Sideroblastic anemia, characterized here by normal iron, but there's a problem with the incorporation of the iron in your heme. So, hindi mo ma-incorporate ang iron sa heme natin because you have a problem with the enzyme. Here in the sideroblastic anemia, you might be because of the defects here in your alacentase or even in your ferrochelatase. So basically for this one, this is the enzyme that try to incorporate our iron to your heme in order for that to become your protoporphyrin ring. I mean, it try to incorporate your iron to your protoporphyrin ring to become your heme. And therefore, pag sideroblastic anemia, you have much of the iron in your plasma pero hindi sila na-incorporate sa ating protoporphyrin ring. And therefore, what you have in peripheral blood with the presence of your ring sideroblast. That could be identified here by our Prussian blue stain, which is a stain for iron granules. That could be eventually found here in our sideroblasts. Okay, we have here the etiology of your sideroblastic anemia. It could be inherited here as sex-linked recessive. So again, pag sex-linked recessive, male will always be the one affected, and the carrier ng abnormal recessive gene that results here to the production of this disorder is the female na mother. Another one, you could also be have here your sideroblastic anemia due to exposure to your toxins or drugs or even your medications. And that's considered here to be an acquired type of your sideroblastic anemia. Example for that, you may expose here to your chloramphenicol or even to your alcohol or even your drugs for your tuberculosis treatment. Idiopathic type of your sideroblastic anemia is just a pre-leukemic. So, pag pinabayaan mo siya, that could eventually progress here to become your leukemia in the form of your acute myeloid leukemia. Again, that's your idiopathic na refractory sideroblastic anemia. Okay, the next one, na microcytic hyperchromic, we have your lead poisoning. So lead poisoning, exposure to your lead may be in the form of your inhalation of the lead oxide, especially working in the mga battery or even automobile, mga engines or batteries, or even sa mga toys, di ba, yung mga dark colored na toys. So usually they are containing the lead. Your lead try to cause your anemia by interfering your heme synthesis. So pag inhibit your heme synthesis, hindi ka makapag-form ng ating heme, and therefore that will have your defects with your hemoglobin production as well. So your lead try to interfere with the RNA synthesis basically by inhibiting the enzyme pyrimidine 5' nucleotidase. This enzyme try to degrade your RNA. So pag wala kang pyrimidine 5' nucleotidase, your RNA will not be degraded. Your RNA will accumulate in the cytoplasm of your RBC. If you try to stain that one, it will able to form here your punctuate basophilia or your basophilic stippling, which is one of your inclusion bodies. Okay, so patient with the lead poisoning here would have bluish-black precipitate in their gingiva of their gums. And the removal of your lead is by our chelating agent. Example for that would have your EDTA. Another one, microcytic hyperchromic, we have your Shahid-Nathan-Diamond syndrome characterized by congenital microcytic hyperchromic with iron overload. Congenital, so inborn, overload na iron. So, sobrang dami ng iron ni patient sa plasma natin. So, it's not normal then. So, that's would have here increased serum ions. Storage iron niya, we're also expecting that one to be increased. And with that, ang ating mga transport protein, transferrin, since madami ang transport, bababang level niya. At the same time, it will also have here decrease ang level ng ating TIBC because our TIBC correlates with the concentration ni transferrin natin. Since kung anong level ng transferrin, ganoon din ang level ng ating TIBC or your total iron binding capacity. Then the last one, thalassemia. Thalassemia, so this is a quantitative defects, primarily with a defect in your globin chain production. Pag sinabing quantitative, wala ka talagang pinaproduce na globin chain. Remember your hemoglobin, di ba? Like hemoglobin A1, dalawang alpha, dalawang beta. So pag sinabing globin chain defects, isang alpha doon, wala siya, or isang beta doon, wala siya. So that's your thalassemia. We have a separate discussion with your thalassemia, so I will not further discuss this one, so it will be discussed na lang sa thalassemia na discussion natin. But then again, we classify your thalassemia having this blood picture of microcytic hypochromic anemia. Differentiating your thalassemia with the iron deficiency anemia ulit with the red cell distribution with the RDW. Again, your thalassemia would have a normal na RDW result, whereas your iron deficiency anemia would have an increased RDW na result. Okay, then we have also here your normocytic normochromic anemia. So, again, ang MCV nito within 80 to 100 FL, your MCHC within 32 to 36 grams per DL. The first one, we have your anemia of your renal insufficiency. So this is characterized by the decreased erythropoietin production because remember that your erythropoietin is being produced by our kidney. So if a problem with the kidney, your erythropoietin will also be decreased. And your erythropoietin is the hormone responsible for the RBC production. So since walang pinoproduce na erythropoietin because you have a kidney problem, so expect also na wala ka masyadong RBC production. Another one, anemia of your endocrine disorders. So that's related here to the problem in your endocrine gland, like problem with your pituitary gland, thyroid gland, adrenal gland. Another one, we have your aplastic anemia. Aplastic anemia characterized here by the decreased production of our bone marrow by our different cells. So it would have your problem with RBC production, WBC production, or even your platelets. The first one, we have your Fanconi anemia. Fanconi anemia is considered here as a pancytopenia. Pag sinabing pancytopenia, your bone marrow is not really producing all cells in our body, including the production of your RBC, production of your WBC, and production of your platelets. Another one, we have your congenital erythroid hypoplasia. This is your diamond black fan syndrome. So this from the word itself, erythroid hypoplasia. So the problem here is only the production of your RBC. It would have here the normal production of your WBC, normal production din ng platelets. Only that, it affects only the RBC production. Mababa o hindi siya na-produce ng RBC natin. So you could also have here your secondary or acquired. Para sa mga acquired disorder, is more of the exposure to your chemicals or even to environmental factors. So example for that na nag-induce ng bone marrow hypoplasia. Pag sinabing bone marrow hypoplasia, hindi siya nagpo-produce ng blood cells. Example for that, we have your chemotherapeutic drugs na methotrexate. Okay, so this one try to induce your problem with the production of our blood cells. Okay, next we have your myelopathic anemia. So this is characterized here by the problem in the production of your bone marrow because your bone marrow has been infiltrated by fibrotic na tissues, granulomatous na tissues, or even neoplastic na mga tissues. And therefore, hindi siya makapag-perform well because may ibang mga tumutubo doon sa ating bone marrow. So this is maybe due to the following here. Metastatic carcinoma related to your cancer. So usually pag cancer, the cancer cells here try to proliferate. It could go to your bone marrow, affecting the production of your bone marrow with your blood cells. Granulomatous in the case of your tuberculosis. Myelofibrosis with your MMM. That's your myelofibrosis with your myeloid metaplasia. So this is characterized by the presence of your teardrops or your dacryocyte. Storage diseases, in a case, for example, of your Niemann-Pick disease, Gaucher disease, again, they're still part of your myelopathic. Okay, then we have here the last classification or the last type of your normocytic normochromic anemia. We have your hemolytic anemia. Hemolytic anemia will always be suspected if the patient would have an anemia in the absence of the blood loss. So, mababang hemoglobin ni patient, wala siyang blood loss. So, that's your hemolytic anemia. So, we have here the manifestation of your hemolytic anemia. The first one, the absence of the blood loss. RPI, reticulocyte production index, more than 3. So, sobrang dami ng reticulocyte production. That will signify that you have hemolytic reactions. So we have here hemoglobinuria, hemoglobinemia because of increased red cell destruction. Polychromatophobia that's related to your increased reticulocyte. And we have here the presence of the nucleated RBC because much of the RBC is being produced as a replacement for those mga massive na RBC which has been destroyed. Okay, we classify your hemolytic anemia as intracellular defects or extracellular defects. Pag intracellular defects, mean to say nasa membrane, ang problem ni RBC natin. Could be related to your membrane defects, like in the case of your hereditary spherocytosis, hereditary eleptocytosis. Could also be enzyme defect, like for example, your glucose-6-phosphate dehydrogenase deficiency, or you could also have here the pyruvate kinase deficiency. Another one is your hemoglobinopathies. Is also normocytic normochromic ang kanyang blood picture. as with your hemoglobin S, hemoglobin C. And we have also here the extracellular. So extracellular here, red cell destruction, something to do with the environment ni RBC natin. That would allow the RBC to lyse or to be destroyed. So example for that, we have your immune hemolytic anemia with the presence of your autoantibody or your mga antibody reactions. So we have your warm type autoimmune disorder that involve here the IgG antibody. Cold type autoimmune, on the other hand, is involved here ang IgM antibody. Or it could be related to other factors in environment that results in your fragmentation like mechanical, valvular, or even in the case of your microangiopathic anemia, with the presence predominantly of your schistocytes. Okay, thank you.